Taylor asked, if the patella is good, why do they need to get rid of it? Sometimes they don't. They'll do what they call a hemiarthroplasty sometimes and just do one part of it. But more times than not, the studies show, and I've done a bunch of research on this because that will be me, that they'll probably just go ahead and just do the total, just get all new. You don't have to go back in there again if something fails. Mallory was asking about time spent in the hospital. That video was saying 3 to 5 days. Nope. These are all pretty much outpatient procedures now. Yeah.
They're going home the same day.
They're going home the same day. They may be there for 23 hours, but yeah, they're going home. They will receive therapy on site. Anybody set up for Jack Houston? Coker, you get to see a bunch of this stuff. Yeah. Jack Houston's a hospital in Phoenix City that does all of Houston's total joints and so forth. Well, not all of them, but a bunch of them. And yeah, they just it's quite the
It's very like
the mill, if you will.
you're just like,
but they do a great job.
heel slide, how to do the stairs if they have stairs at home,
Yep.
how to walk properly.
Use of assistive devices, fitting of assistive devices.
Isn't it now you have to see them a minimum of like 3 times and then they can go if they're cleared?
So,
I have no idea.
I didn't put something.
Because they have to do up within an hour and then 2 times the next, because they usually are done later in the day now.
Yeah.
They stay the night and then up in the morning, up before they do discharge.
So you have to see them twice?
At least twice a week. Sorry, it's really hot.
So complications, nerve damage, you can see how that could be the case. Loss of motion, that's probably the most frequent. Extensor lag we talked about. That's another word for quad lag, extensor lag. DVT, we've hit that a lot. Pneumonia, infection. All those are pretty rare, to be honest with you. I'd say the loss of motion is probably the most common complication. Post-operative management, there is little to no immobilization. Basically they will put I love this now because you don't have to worry about all the wound care and all that stuff. They will put this kind of shrink wrap over the incision now, vacuum sealed type of thing.
Yeah.
It's great.
Aqua seal.
Yeah. It's just a super adhesive bandage, and you don't even have to check the wound and all that kind of thing. That's for what they go back in to see the doctor. And you just early motion, just get them moving. I've had people that got to 90 degrees 3 days after surgery before. And it's all about getting them in the right mindset. It's okay to push it. It's okay to be a little sore. Now, we don't want things squirting out and them in so much pain. You know, the first time they come in, when I do the evaluation, I'll say, all right, how far can you bend it? And a lot of times it'll be like, oh, and it gets to here. And then I'll start talking to them or whatever, and I'll just say, okay, just let me have it. And I'll just slowly bend it for them. And they get to 75, like in 20 minutes without even doing anything. So it really goes pretty quickly. Weight bearing considerations, again, there's full weight bearing unless there's something really out of the ordinary. And again, the exercise progression, we'll talk a great deal about it in a minute. Actually, the next slide. Maximum protection phase, and I would say this 1 to 4 weeks. I would probably even say that's probably even closer to 1 to 2 weeks, 1 to 3 weeks now. They do come to rehab usually 1 to 2 days post-operatively. I've seen some the next day. I've seen some that were a week. That's when it's really a struggle, because if they haven't been doing something at home and they've been sitting at home for a week with a pillow under their knee because of insurance problems or whatever, that's going to be a stiff knee. Then you have to get it moving. Yes, ma'am.
How do you know like what's too much like to push it like as a PT or PTA? Like I don't know, like in the clinic on Friday there was a lady who had a total knee and like they were trying to get like a goni measurement, like trying to get her to whatever, and they were pushing it and she was like rolling all over the table.
Oh, yeah.
She was like in a lot of people. Like I don't think she was faking because like she was clearly not
Very
faking.
demonstrative, let's say.
Yeah, but like she was really trying not
Yeah.
to like scream or whatever. But it's like, how do you know, like, when to like push it further and when to not?
I've really pushed people before, and I don't think I've ever had anybody come back and say,
I think it just
you hurt me or
depends.
anything like that. It's just, yeah.
Depends on your patient, like you get to know what what their threshold is, their pain tolerance. Also, it really depends on how far out they are. If they're 1 month out and we're only at 9 degrees, I'm cranking on it.
What,
Sorry.
and I think to avoid that is get them with the mindset right off the bat that it's okay for it to be sore. It's okay to push it. It's not okay to just stop when you start to feel some discomfort. It's okay to push through that.
I also think it's like a mental thing, cause like I have this lady, and she's probably on like week 6, and she screams and hollers, like, I mean, she is just screaming so loud. Anytime we get that goni out, she is stuck at 105.
Yep.
Last week, well, we got her to 108 because somebody jammed it.
Yep.
But I see her on every Friday, and she doesn't do her ATP because she's like, no, it hurts, it hurts, it hurts.
Right.
And we have to basically trick her into doing, like, to flex. Like, we can put her on the bike, and we'll just start talking to her and, like, physically moving it for her,
Yep.
and she can get up there. But the moment that she sits down and you gotta do it, she
And you get that goniometer out, they kind of get that, yeah. Yeah. There's all kinds of ways
You
around
have
that.
to like know when it's time to stop saying things with icing on top of it, and it's time to be real. Like the first visit with a patient, when they're with me and I see that they're already struggling, I'm already having that conversation with them saying, it's usually him, because it's usually the guys that are girls do great. But it's time to have that conversation early. The
That's
earlier
so
you can have
not
that
true, though.
conversation.
That is so not true.
It is
The little old ladies that, when I start bending it, and they're like, oh,
I've
oh,
only
oh,
had
oh, oh,
one
oh,
lady.
oh, 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 that hurts, that
I've had
hurts.
one lady that has gotten a minute. My other minutes are all men. I had one lady, she had her boyfriend in,
Obviously
she'd be
treat
like,
no
"I don't
whole
feel
females, no.
She was really sweet though.
So looking through here at the goals, controlling postoperative swelling is huge. How are we gonna do that? Ice.
They're gonna hit their own
Combine it with something else.
compression.
Compression. All kinds of good compression cryotherapy units out there now. A lot of times people are getting sent home with these, which is fantastic. Makes things so much easier. And they're so much more pleasant to deal with because it helps with the swelling and the pain, which is gonna help the motion and help everything else, so huge. Tell them to take their pain medication. There's a reason that they give them this stuff. They're not gonna get addicted to it for taking it for 3 or 4 days, especially post-operatively. Take the pain medication. Tell them to.
We want to like properly instruct them on how to take it.
Take,
Like a lot of
I always say,
people will
take
just
it
take
as
it-
prescribed.
Yeah, a lot of people just take it when they feel the pain start coming on.
Right. Take it as prescribed. And taking it before therapy, if they've got a ride, most of these people are not driving. If they can take it before they get there, oh, so much better. Get so much better results. Range of motion 0 to 90 in this first 4 weeks, yeah, you better be at 90, I think 2 to 3 weeks, is that what you were saying? I agree.
2 weeks.
Yep. 3 to 4 out of 5 strength quadriceps. You know what I think of that. Ambulate with or without a assistive device. So what's the natural progression? What are they gonna walk out of the hospital? They're gonna roll them out of the hospital. But from the hospital to their car, walker. Rolling, standard, probably, yeah, you can see both. So they're gonna come to you the first time. 90% of them are gonna be on a standard or rolling walker. When do you get rid of it? What's the answer to everything?
It
It
depends.
depends. It depends. Premorbid state. They may have had problems with the other knee previously. That's going to take it a little bit longer. But get rid of the walker probably in the first week. No? 2
I
weeks?
usually wait for them at least 3 to 4.
Wow.
Because we're one motion, so if they're not getting their motion when they swing, go to swing phase, they tend to do the hip height
Yeah,
thing.
you don't want that.
And then their back starts to hurt and their hip starts to hurt. So, and then also quad, if the quad's not sufficient, they're gonna give out with the pain. So sometimes it's, for me, I like to wait at least 3 to 4.
Okay.
Make sure we're focusing on the early stuff first.
And a lot of times, this is gonna be, because they're seeing a doctor, they usually see a doctor 3 to 5 days post-op. They'll see a doctor 2 weeks post-op, 4 weeks post-op, 6, 8 weeks post-op. So they're going to see him every couple weeks or so. A lot of times the doctors say, get rid of that. And a lot of times they have to hear it from them. They just don't trust us for whatever reason. So that's fine.
Also, sometimes when you let them go onto a cane, it's like you give them an inch, they take a mile. So they think, oh, I have free reign to do whatever I want now because I'm not restricted by a walker. So they go into Walmart and shop for 2 hours. Well, what happens after they get done? They're swollen, they're in pain. And then so they don't move for a couple days or a day or two because they're also swollen pain. Then range of motion becomes an issue again. So it's like a battle between fighting that you're fighting with the inflammation.
Give me the person that wants to shop for 2 hours.
Me.
So again, really important that they are, on that first visit, when I see them for the eval, the last thing I want to ask them is, all right, so let me see your homework. And I know you've been taught that you've got to be doing ankle pumps, heel slides, quad sets, maybe even some straight leg raise for glutes. Before they leave the hospital, they're supposed to do this, and they've got a paper at home. So if they don't know how to do those on day 3, I know they haven't been doing it. So that's a point I'm going to reinforce over and over and over. You cannot do these things enough. Can't do them enough. Nobody's going to get that sore from doing quad sets, okay? So many times as they can do it. When we start getting into this moderate protection, and again, I don't really love this term because it's not a protection phase, it's just a natural progression. Because you're really not protecting anything here. I agree with Ms. Ann. Range of motion needs to be beyond 90 at this point. At the end of 8 weeks, if they don't have 115 to 120, it's going to be a struggle to get it because things are just getting stiffer and stiffer. Okay. Yeah. And goals, I would say 120 is pretty much the standard, right? Wouldn't you say? Yeah. You give them a 120, they can walk without a limp. They can do almost a full squat, all that.
Usually what happens is the rest of the motion's gonna be acquired by functional activity on their own within the next year.
Correct.
So there's no point in you cranking it because they'll come naturally.
So let's talk about this moderate protection phase. What kind of exercises would you anticipate giving them? You've already had them do all the mat stuff. I hate doing mat stuff in clinic. I hate that. Let them do that stuff at home. Figure out stuff that they can do in the clinic that they need your expertise. So get them up on their feet. What can we do in between these two phases? In these two phases that shows some skilled care.
Weight shifting.
Weight shifting is a great one. I love putting them on like an Air X and have them shift weight forward, backward, march in place. They can do heel raises on that, even little mini squats and things. Okay.
Progressive squat progression.
Squat progression is huge. You want to get them to where they can go from sitting on a low mat to being able to do that, sit to stand with no hands. Okay.
Step ups.
Step ups. If they've got stairs, you got to address it early. Absolutely. And I will do step ups, side step ups. I play around with the stairs. I use the stairs a great deal. I love the stairs for range of motion. I will put their foot on the second step and then have them lean forward. It's a great way to stretch. Yeah.
Do you like cone step overs?
Which one now?
Cone step overs?
Cone step overs. That's a little bit more. We're getting to where we're getting onto this end of it. But yes, if you got somebody who likes to shuffle their feet, their gait pattern, absolutely getting them to step over something is a great tool. What else? Anything?
Hamstring curls.
Hamstring curls, just in standing against gravity. You can put an ankle weight on them. You can put them on a machine if you feel like you really need that. I don't do a ton of hamstring stuff because if they're walking, they're getting a good bit of hamstring stuff. So that's just my philosophy more than anything. I'll put them on a treadmill and maybe incline them a little bit too. That really makes them grab. What else?
Danielle mentioned step up, but what's also important when we talk about steps? Step down.
Step down's even more important. Yep.
Like,
That's when they're gonna
central
fall.
control.
Jazz, were you saying, you ready to say something?
I said knee extensions.
Knee extension. Tell me about that.
You can use a machine or you can put an ankle weight on them.
Okay.
We
What's
did
that gonna do?
one-
Let's talk about this. It's gonna strengthen their quads? I would agree. Is it also gonna compress their patellofemoral joint? You talk about sitting like this and doing this, right? Open chain knee thing? I just do because I feel it in my patellofemoral joint every time I do it.
Compressing?
Absolutely.
What is
Absolutely.
compressing?
Because of the weights here distally, when you come up, you're gonna compress this. You'll create business for ourselves if you do a lot of that. Now, does it isolate the quad? Absolutely. But I would much rather work somebody's quad in a standing position, closed chain, because you'll get everything else co-contracted. Yep.
They do an extension exercise at the clinic where they put them up against the wall with a ball behind their knee.
Uh-huh.
And just push back.
Terminal
on
knee
that
extension,
ball.
that's a great one. I really like that. I like it because it's in weight bearing too. We'll come back to your thing. We'll talk about that later.
So it's like a short arc quad?
Short arc quad. So again, it's kind of a mat exercise, so I don't do a whole lot of it, but you put something underneath them here and then have them do extensions here. I like that better than I like the long arc, just because there's less compression there. You can put a lot of weight on it if you really want to get them stronger. All right, we pretty good on that slide? We feel confident that we can progress somebody through that? We'll practice it in the lab. So here's all the exercises that I didn't want you to see, just trying to get you to think a little bit. Outcomes. Pain relief, that's why they have the surgery. They should not hurt after, gosh, what do you think? 2 to 3 weeks, pain-wise, should be pretty minimal.
The surgical pain should be gone.
Should be gone, correct, that's what I'm talking about.
The exercise discomfort is going to be there.
Yep. So hopefully, again, in that moderate phase, you're looking at lower levels of pain, because you don't want to have to be fighting that. Because think about it, the arthritic pain is gone. It doesn't exist. There's no more bone on bone. They have no nerve endings in the prosthesis, so it's impossible to feel that arthritic pain.
So how do you differentiate between like it being exercise discomfort and too much for the patient?
Totally depends. Like she said, you gotta know your patient. You gotta set expectations early. I think that's really a big thing. It's okay to be sore. It's okay to be a little swollen, because that means we're progressing.
Also, what appropriate questions can you ask them to differentiate the two?
What type of pain?
What kind of pain?
Yes.
So at what point in this process do you like refer a patient back to surgery? Because we talked about like if they're to the point where they're so stiff they might have to go back in surgery.
Again, they're going back to the doctor every 2 weeks for the most part. You don't have to. If you've got somebody that's really stiff, everybody's gonna know. Patient's gonna know, PT's gonna know, PTA's gonna know.
So like when they come back, do you just start all the way over quickly?
What do you mean start over?
Like if they come back from, okay, let's say we had a patient that had to go back into surgery. They gotta come back to PT.
Oh yeah.
So like, do you just start like from the minimal phase all the way over?
No. You're probably just gonna be working on range of motion at that point.
And you're even more aggressive.
Way aggressive. And they're probably coming daily if they have to go back.
Daily for 2 weeks.
Yep. If they're that stiff and they've got to go back under anesthesia, and there's 2 options that they can do. They can do a closed manipulation where they just take it and just move it while they're asleep. Tears adhesions and does all this stuff, and can actually disrupt the prosthesis as well. I've seen that before. That's no good. Or they can do a semi-open procedure where they actually go in and remove scar tissue. There's one of two. But the end goal is still the same from a therapy standpoint. You're gonna see them daily, and you need to really emphasize the range, because you don't want them to lose whatever they gained in there. My wife's got a lady right now who is stuck at like 108 and can't get any further. She had manipulation once, and the doctor said, "Oh, I got her to 125," which, no way. Like, she knows.
Cause this is what they do, they go,
Yeah,
that's 125.
125, yeah.
They
And
don't let it go now.
now she's back to 108, and she's just, it's just gonna be what it is. But you see this minimum right here, 100 to 110 for function. If you get somebody at 120, they can do just about everything. 110, between 110 and 120 is good, not great. Anything below that 110, not satisfactory. They're gonna have struggles with everyday occurrences with their knee. Recommendations, activities. This is important, and this is something you as a clinician need to go over with them. These things are highly recommended, okay? Non-impact activities, okay? If they've done these things before they had surgery, it's theoretically okay for them to go back to doing, alright? And these are the things that are flat out not recommended. And these are impact activities with dynamic twisting, turning, jumping, all this stuff. That joint is not designed for that. They might do them, but what's gonna happen? The prosthesis is gonna wear down much quicker, more risk for complication. They're probably gonna have the surgery, replacement surgery again, or what they call a revision, much sooner than anticipated. All right, patellofemoral pain without malalignment. This is somebody who's just hurts under their kneecap. It happens all the time. And you can't really see any major malalignment. You don't see a huge Q angle. You don't see anything, but they just hurt. What do you do about this? Okay? This can be a result of osteochondritis dissecans in the patella, or the femoral trochlea that it goes into. It could be a result of tight medial-lateral retinaculum. Chondromalacia, remember we talked about that? What does that mean? Chondro means cartilage. Mal is bad, so bad cartilage, and that's the underside of the patella. These are the people that have lots of problems sitting for long periods of time. Patellofemoral arthritis is just degradation of that articular cartilage there. This can present very similar to the chondromalacia. Apophysitis. Okay, we got Osgood-Schlatter. So this is an overgrowth of the tibial tuberosity. Has anybody seen this before? Guys, anybody had this?
That's what I heard.
You have this too? So this tibial tuberosity, because of the pulling of the patella, just starts building up tissue, and it will actually rise and swell, but it's hard tissue, and it's usually very, very tender to touch. You'll get a lot of adolescents who perform jumping. So volleyball players, you've probably seen this before. Volleyball players, track athletes, basketball players, very, very common, okay? And then Johansson disease is the inferior pole of the patella. That's less common, but that's the same thing that occurs down here, more bony growth as a result of stresses. Bipartite patella is a patella that has fractured, okay, in half. There are a lot of people that are born that way. It just doesn't come together. I don't say a lot, but it happens. Bipartite patella can be symptomatic or asymptomatic. There's plenty of folks that have 2 pieces of the patella and they have no symptoms, but a lot of times it does have symptoms. You can imagine that can be problematic. And then trauma. Somebody falls onto their knee. I slid into home plate and my patella was back here. That's traumatic. That doesn't feel good. Therefore, I'm gonna have problems. Non-operative management, again, we're gonna talk about what we do manually and with exercise, but again, lots of different things that can cause this. What's it gonna present with? Pain, crepitus, what's crepitus? Crunching and grinding. Is all crepitus bad? Nope. I only pay attention to crepitus if it hurts. If it just is normal, I mean, if it's, they normally make sounds when they squat and so forth, it doesn't hurt, don't worry about it. Usually you're gonna see weakness, maybe some malalignment. You may see some tracking issues. Again, tightness in the retinaculum, IT band, pronated foot, we talked about earlier. It's gonna create more valgus. And then you're gonna see these functional limitations along with them. So what do we do for these people? It's a tough population to deal with, honestly. More times than not, this is gonna be the young, adolescent females that are active, runners, in volleyball, dynamic sports. You see it a lot. And it's not that you don't see it with guys, but I think I see it a whole lot more with females due to the Q angle, weaker quads, weaker glutes, more alignment issues, and they tend to be a little bit more hypermobile. So that patella tends to just kind of just be really loosey-goosey. We don't want that. We want it to be mobile, but we don't want it to be hypermobile. So modalities for pain and joint fusion, certainly. We can do that on anybody that has pain. Rest and activity modification. Give me an example. Stop. Are they gonna listen?
No.
No, they're not. So let's be realistic. So instead of going and running and jumping 5 days a week, let's try 3 days a week or 2 days a week, okay? Be realistic with this. Patellar taping, we'll talk about a little bit today. Muscle setting exercises, what do those mean again? Isometrics in a pain-free position. There's lots of things that we can do to keep the muscles going, prevent the atrophy, and in gentle range of motion in a pain-free range. If it hurts to bend it past 90, we're not gonna bend it past 90. These are not people that are gonna get problematic stiffness for the most part. These are the people that are too loose for the most part. So we're not worried so much of the someone getting stiff. Doesn't really happen in that population. Education, really, really important. Okay, talk to them about their sport if this is what their goal is. Maybe it's their job, whatever it is. But talk to them about it. Learn more about it. That's your job. Mobilizations, again, we'll talk about that. Taping, we'll talk about that at lab. Looking at the muscle control, the VMO. What does a VMO stand for? Vastus medialis obliquus. So the teardrop muscle right here, we need that developed in these people. More times than not, it's really flat, not developed. So we've got to do things to help develop that. You know ways to do that. Modifying stresses. Again, activity modification. Some braces can help. I've seen all kinds of stuff. The knee sleeve with the cutout for the patella, and people will say, oh, that keeps it centered. BS, it doesn't keep it centered. It's just, you think it does. There's no way that if your quad fires, that little neoprene thing is gonna keep that in place. It's flat out not going to. But if it makes you think that, and you're gonna keep things in alignment better, I'm all for it. Whatever. But the goal is to keep this centered this way, north and south. Yeah,
Like, it hurts to the point where, like, cause I had to wear it, and then I got to the point where, like, I'm not wearing this because it hurts so bad.
it compresses more than it does anything.
I don't know what it is.
I didn't like it either. I'm not a big brace guy. Just teach our body to do that. All right, getting on to ligamentous injuries. The unholy or terrible triad. We've talked about this before. This is going to be a blow from the outside of the knee, and it's going to take out MCL, medial meniscus, and ACL. Very common in soccer, football, contact sports, even basketball. See a lot of this type of thing. We know that the anterior cruciate ligament limits what? Anterior translation of the tibia, okay? Posterior ligament is going to limit the posterior translation. So again, most commonly, this is done below to the ACL, below to the lateral aspect with rotation. PCL is going to be mostly someone gets hit here, whether that's a dashboard, whether it's somebody kicking in soccer, and just clears them out this way. Medial collateral is valgus, so that's hit from the outside and bends this way. Lateral collateral hit from the inside, creates a varus stress and disrupts it laterally. Much more infrequent than the MCL. MCL is probably the most frequently injured ligament in the knee, for sure. Very easy to tweak that. But the good part about that is that it heals on its own. No surgery required if it's isolated like that. Indications for surgery: location and size of the lesion. If you've got a partial tear, can things heal? Yeah, they can. They don't always, but they can. ACL, PCL, and lateral collateral. So all of them, except for the medial, do not get great blood flow to themselves. Okay, so they're not going to heal themselves per se. They've got to have fibers realigned to do that. MCL can do that because it's so closely adhered to the joint, has better blood flow. Concurrent injuries we talked about. It's very rare that you're going to have just an ACL. More times than not, you're going to have some concurrent meniscus or collateral ligament damage as well. The degree of instability. There are plenty of folks. I have a very, very close friend of mine. He's a great athlete. He's 50-some years old, plays a bunch of tennis, basketball, all this stuff. Born without an ACL. He does fine. He does fine. He's got really good, strong legs, good, strong quads, strong glutes. Yeah, he always tells a story when he went to the doctor as a kid and they figured out that he didn't have an ACL. Doctor said, I want you just to ride your bike all the time. Ride your bike everywhere. So he did. He got really, really strong legs and he's fine. He doesn't have any arthritis in his knees. He got better knees than I do. But if you have this degree of instability of some sort, you're going to have more of a risk of what? Not only subluxation, but even the osteoarthritis, because you're going to get more banging bone to bone, okay? So if somebody has, my son's therapist she's in her 30s, and she had an ACL injury when she was a kid, and she was not an athlete. The doctor said, do you want to have this surgery? She says no. But now she's got more knee problems because she did not have that surgery. So if you've got if you're just beyond sedentary, if you're doing anything activity-wise, getting those ligaments, especially ACL, repaired is probably going to be recommended. Almost all of these now are arthroscopic in nature, very, very few open surgeries. There's a difference between a repair and a reconstruction. We'll talk a little bit about that later. Graft types, all kinds of things here. So when an ACL gets torn, where's my little knee? right, stand up again. Cross right over left. Which one's our ACL? Right. Okay. Prevents that anterior translation of the tibia this way. Okay. PCL's back here. Prevents that posterior translation. Collateral ligaments here. You also have our menisci, right? If we're looking down at a right knee, this one's in the shape more of a C, and this one almost goes completely to an O. Okay, so the lateral's a little thicker than the medial. Let's see if anybody did any prep reading beforehand. In terms of the meniscus, where is the more vascular area? The inner or the outer? Let's stay standing if you think it's the outer, and sit down if you think it's the inner. Wait a minute, what did you just say?
I don't know,
Don't follow their lead.
I don't know.
You were right.
Which
It's
one was
the
it?
outer part. The outer part has more vascularity, okay? So that.
I didn't know which one was sitting, which one was standing.
I'm not even sure you sat. You like
You
half
said it right.
squatted.
You said it
That's
right.
why I was like,
The outer
I don't know
part,
which one it
the outer
is.
part is the red zone. The white zone is on the inside, less blood flow, okay? So if you have a meniscal tear that involves the white zone, it's gonna be hard for that to heal itself. On the outer zone, it can kind of wedge itself back in and maybe get some blood flow and heal itself, or at least could be repaired. Okay, we'll talk more about that later. Good work. Yeah, you did. 50-50, trust yourself. Graft types, all kinds of stuff out here. You can get a hamstring graft. You can get a patellar tendon graft. You can get a gracilis graft, or you can get a graft from someone else, an allograft. Okay? What's the gold standard? Anybody know? What is done more in terms of ACL reconstructions? What tendon is used the most? Patellar. From someone else or self? From yourself. On the same side or the opposite side? Same side, yes. That's the gold standard. If you get it right ACL and you need a reconstruction, the gold standard for the most part is they take the middle third of your patella tendon of the same side to make that new ligament, okay? And if you're interested in learning more about the surgery, feel free to research that yourself. We're not gonna spend a bunch of time with that, but they drill a hole and they take that tendon and they make that a new ligament. We're gonna talk more about the considerations here. Outcomes. All right, so we've got to keep stability is the purpose of the ACL, right? We've got to get stable and we've got to regain motion, okay? Obviously pain-free and stable weight bearing. Hopefully we're doing that pretty much on day one. Sufficient strength and functional restoration. Most of these folks that have this ACL reconstruction are more athletic types for the most. It's pretty hard to injure an ACL without some type of bending, twisting going on. It just doesn't slip and fall. It usually doesn't happen. Preoperatively, after they tear, we want to control swelling. That's a big one. And start talking to them about this prehab process, because obviously they don't usually like to do an ACL repair. You know, if someone tears theirs, they'll usually give it at least a week, 2 weeks, maybe even a month to let swelling go down before they're going to have their surgery. Something they can avoid it at times. They can go after it, but there's more risk for infection and so forth. Post-operatively, there's a bunch of different protocols we're going to talk about, and I've given you a few on Canvas, but we'll hit the highlights here of those. Again, indications: significant tear, frequent buckling, so instability during ADLs, okay? Again, we could certainly see a lot of concurrent injuries and a high risk of re-injury. So if they go back to their work or their sport, if they don't have this thing repaired, odds are they're gonna end up re-injuring it in some way, shape, or form. So that's gonna be the check boxes here for when they have surgery. Post-operative. All right, so people have seen this. You see this brace that this guy's got here. That's called a Bledsoe brace. It's got uprights on both sides, and it's usually got a dial in the center here that can control the amount of motion that takes place. I think you guys have all seen these, right? They've got Velcro stays through here, a big dial on the side, and again, it can control how much flexion extension. Yes, ma'am?
Is it the PT's job to determine that? Amount?
No, they're gonna come to therapy in that brace.
No, but like what time they're allowed to up the range?
Yes.
Okay.
Yes, there'll be a protocol that they'll follow. At week 4, you're gonna do this, and we'll actually go through that a little bit. But that varies too. And some people don't even use the braces, so it's all very mysterious. A lot of people think that they get these braces because the reps make much money off of these braces. So there's very little that says that they work. I still think most of the time the insurance is going to cover it. Insurance covers most of the post-op ACL braces now?
Yes,
Yes.
unless they're, like custom.
Yep. So the off-the-shelf brace runs about $200, $250, and the custom one is up to about $1,000. And the custom one versus the off-the-shelf, really not a whole lot of difference in the outcomes. Weight-bearing considerations, weight bear is tolerated. Get them on their feet. Exercise progression, this is what we're gonna spend most of our time on here. All right, maximum protection phase, so 0 to 4 weeks. You will probably see these pretty similar, probably 3 days, a week after surgery. Really trying to enhance range of motion. So goal of getting to 110 by week 4, pretty lofty, but again, you're dealing with a younger population than you are the total joint, so the range should come a little bit easier. But to get that range, you're gonna have to work on swelling. You've got to work on decreasing that swelling. Weight bearing as tolerated, yes, we talked about. So they'll come in crutches, and a lot of times they're not gonna wanna put any weight on it. That's our job. You've gotta put weight on this, okay? And I will take one crutch away very quickly from them. Rest, very, very little rest. I think this means more rest to the healing ligament. Protection, definitely have to protect the ligament. We're gonna talk a lot about that in a few minutes. Patellar mobilization, get the patella moving. You've heard me talk about this a lot already, but get this moving because that's gonna help this, okay? If you've got it stiff here, it's not gonna bend very well. So we need that mobility. Cycling is it's the best, I think. Get somebody on a bike and get them going around. Once they get to 90, they'll be able to go around on the bicycle. They'll always, if you have them go backwards first, that's the way they'll do it. They'll jump out of the seat the first time they go around, make noise, all that stuff. But then they're like, oh, that didn't kill me. And it feels better, so let me go a little more. And then you move the seat a little bit, and go a little bit more. And then you're up to this 110, 120, and you're home free. Active motion, lots of flexion, lots of extension, open chain. We're not gonna do a whole lot on their feet. I disagree with that. I do more closed chain right off the bat now than I used to. I get them up and on their feet. Now, when we get to week 4 and week 10, we need to be, again, that's roughly 2 months, we've gotta be at full range by the end of that. And you've gotta be improving the strength. Gait needs to be normal. So strength's gotta be enough to where their gait's gonna be normal. What does SLS stand for? Single leg stance, okay? Do a lot of single leg stuff. P and F, all kinds of things you can do with that. We'll come back to that. Closed chain, again, on their feet as much as we can. Stretching, gotta look at hamstrings, all that kind of stuff. Towards the end of this, you can start, if they can walk without a limp, they can start to jog. Again, straight line, nothing, no change of direction, straight line. Yes, ma'am.
Okay, like we said earlier with the total P, how do you know it's too much with a patient with this? Because like, you don't wanna like re-injure your ACL like too early because like that's just miserable for them. But how do you know like dealing with athletes, how do you know to push them without pushing them?
Okay, that's a great
Because
question.
athletes are hard hit, and they gonna wanna push more.
They're gonna wanna push. Okay, so can I give me about 2 minutes and we're gonna talk a lot about that, all right? When we get to those higher level activities, actually, let's talk about it now. So, the graft, that's the key. It's science. Makes it a little bit easier. When do you think, so if we're taking that patellar tendon and putting it in as a ligament, when is it the strongest? 6 weeks? Wrong. It is the strongest when it's put in there. This is what happens. Okay? So this is our timeline. This is strength of the graft. And this is time. So, it is at its strongest on day 1. So let's say it starts to go down. When does it bottom out and start to come back up? When is the graft its weakest?
It's like when the body finally takes it.
What's that?
When the body finally takes it in as a part of that ligament.
You're
But it depends on.
describing it perfectly, but give me some time frames. What is the danger zone? Because obviously when the graft is weak, in this time frame here, we can't stress it.
Third week,
Getting close.
fourth week.
Getting close.
4 to 8
I
weeks.
usually tell people it's 4 to 10 right in here. This is the danger zone. This is when the graft is at its weakest. And by this point, it's starting to revascularize, just like you were saying, Rebecca. The body takes it on, okay? It will provide blood flow to it, and it will start to heal. So then we're getting back up into here in the 12-week mark and so forth, and we're good to go. But look at this, 4 to 10. Look what we're talking about now. Someone is starting to feel better. They have less swelling. They have more range. They have more strength. And these are athletes. These are people that want to push themselves. So this is when you got to pull the reins in, people, and you got to say, okay, I know you're feeling better. I know that you want to do more. We can only do so much. Yes, ma'am.
So like, how we talked about in previous, like how you would see them less. Would you see them less at that point? Like.
No, actually, I want to see them more because I want to
Restrict them.
restrict. And it's not restriction like they can do all the squats they want to do.
Yeah.
They can do all the walking they want to do. What we can't do is put the graft at risk. We can't stretch it this way. So let's go back to your exercise. Your favorite, you said. If I have a new ACL, I'm a month out, and I've got a weight on my ankle, and I come up here like this, because boy, that makes my quad really strong. Think about that. What is that distal weight doing to this graft?
Yeah, applying pressure to it.
It's applying pressure to it. It is stretching it. And that is not a good thing, especially in that 4 to 10 week. Okay, so you cannot put somebody on that machine and have them do this. I won't even let people put an ankle weight on them and do this. we are going to do closed chain stuff during this time because it's safer. Not only are we dealing with patellofemoral issues here, but preserving that graft during that critical time is paramount. Okay? So I've been doing this 30 years. I've had a couple grafts get stretched a little bit more than I want them to get stretched, and that was just kids being kids. I had one idiot re-tear. This guy was older guy. He's in his late 30s, 40s. He worked like a construction crew or something like this, and he jumped over a ditch at like 8 weeks after his ACL. He shouldn't have been working. Jumps over the ditch, re-tears his ACL. Oh my gosh. I went to the doctor's visit with him because I did the Lockmans on him, and I was like, oh gosh. So I go, the doctor's right across the hall. I walk him over. The doctor used every word you could ever imagine on both of us. And finally he apologized to me afterwards. He said, I know that guy's just a complete idiot. But I mean, it was a big deal. He had to go in and reconstruct the reconstruction, which doesn't go very well. Yeah.
So is this time frame dependent on the graft they get? Because like a lot of patients we even see in our allograft from a cadaver. So is it gonna
It does somewhat,
vary?
but I don't think we know, because we can't do a histological study on somebody in vitro, right?
Mhm.
So we're just going by what we know historically.
Okay.
So I think if you go with this range and just understand this curve, you're gonna be fine, okay? But this is the big take-home message. Yes, sir?
So if you have somebody that like keeps tearing, like not necessarily saying he's doing perfect in therapy, but he's doing good enough, following everything. Cause there's a dude at our clinic that this is his third time having it torn, and they put his Achilles in replace for his ACL.
Yeah.
And this is like his third time having it done. What, like, would you say is the problem with that?
I would say somebody like that's probably got some type of connective tissue disorder, most likely. That it's just, this is not working. But it's hard to diagnose. But three of them. I had a girl, a soccer player. She tore both of them and then tore both of them again in about 4 years. I saw her all through high school. And again, a lot of that's got to do, so do people know the stats? Female soccer players versus guy soccer players? What, how many more ACL tears do women have compared to guys? It's 7 to 1. 7 to 1. So why? Q angle is a big one. What else? Quad strength, glute strength.
Less testosterone.
There we get into the hormonal stuff, absolutely. And they've tried to do correlational studies between women and their menstrual cycle of when they tear ACLs, because we know that there's hormonal changes that occur. Testosterone, guys have an advantage there, yes. Build more there. So there's a lot of factors. The female femoral condyle, right here, is more narrow, right here, that little groove, and it's sharper. It's more, because it's smaller, it's sharper. So there's another reason that it tears more. So there's lots of things that the females have against them. So they have, Cincinnati Sports Medicine has a huge prevention. Anybody soccer players? We've got some soccer players in here. Big preventative push in women's soccer to avoid more of these surgeries. So there's great programs on working on glute strength. You can't change your Q angle, right? but working on quad strength, glute strength, landing properly. So when you see somebody, you can get a pretty good predictor if somebody does a lateral jump and they can, what we call stick the landing. So their hip, their knee, and their foot and ankle kind of absorb the blow. But if you see somebody go over here and then their knee dives in like this, and that's usually due to weakness here. If you see that valgus deformity when they brace themselves, that's who tears ACLs more often. Anybody can tear, but that's when you see more of the propensity for that to occur. Yeah.
So how early do you like implement like ACL training with athletes? Because like when I went through high school in like club ball and stuff, we had like specific like ACL training. So when we learned like
Yes.
how to jump off boxes and stuff like that.
Absolutely.
But
That's
like,
exactly what I'm talking about.
How early do you implement it?
I do it as early as I get them. If I get a female and they don't have an ACL tear and I'm working on something else, I'm gonna have them do those exercises at age 10, 12, all of that. Cause that's 13, 14 is when I usually start to see those things occur. And I want those motor patterns ingrained earlier if we can. But you're right, that's the kind of stuff, box jumps, teach them how to land, how to decelerate their body. And that all sounds good, but that's hard to do. It's very hard to do on a playing field, so that's a good question. But does this make sense to people? I need you to understand this. If you don't understand this, we are in big trouble. Okay?
Are all ligament? It's just the ACL looks like this?
Well, not many other ligaments get reconstructed like this does.
Right.
Yeah. So if you have a lateral collateral ligament, it's gonna be pretty similar in terms of this little curve here. But the ACL is so mysterious in what it actually does, and we know exactly what this does.
Yeah.
It prevents this. But the ACL is going to prevent that anterior transition, but all this rotatory movements as well. It's really hard to quantify.
Tommy John is similar?
Tommy John is similar.
Because of how it articulates.
Yep, it's similar. It's similar. Yes.
So we did ACL training,
Uh-huh.
and like 3 girls on my team like still tore their ACLs.
Yep.
But do you think in those cases, I mean, because we were working on like those muscles that you're saying are weak, so
Yep.
do you think that would have been like more hormonal, or like?
No idea. Could could have just had larger Q angles or this hook in the condyle? They may just have been predisposed to that. Because if you tear it once, your odds are very likely, or more likely certainly, to tear it on the other side too. So we know that there's a lot of just anatomical differences, and we can't change those things.
So if you're rehabbing somebody who had an ACL tear, would you do it on the other limb as well, since it's a chance that they could also tear it?
Yes.
So you do a lot of bilateral.
Yes, I do a lot of bilateral stuff. Absolutely. That's a great question and a good point. So we good on this? Do we understand? Because again, they're going to feel good here. They're getting rid of their swelling. They're getting all their range. They're going to be like, oh, I'm ready to go. I'm ready to do some stuff. We can keep you moving in a straight line, but we cannot have you cutting and moving and jumping. Yeah.
And also going off how you said they feel good, a lot of like the 2 girls I've seen, it's a big mental aspect in those weeks, because they feel like they can do everything, but then your PT has to come and say no, like
No.
you can't do this. So like I've seen like 2 girls break down because they think, oh, I can go 100% right here.
Yeah.
And it's like, no, you can't.
No, physiologically, your body will not let you, even though you feel pretty good. Yeah, that's the hard part. That's the hard part. Because if you stretch a graft out, what good is it? It's just a loose ligament, which is not a whole lot of good, to be honest with you. You're gonna get all that rattling around in there, and that's gonna create more osteoarthritis and so forth. All right. So here we go, talking about all this stuff. This surgery is about 95% successful. It's become very routine. Graft failure on a bunch of different things that we've already talked about. Functional bracing is kind of unclear whether that's helpful or not. Daniel, do you see a lot of bracing?
No.
You don't see it much anymore. Yeah, I think that's definitely the trend nowadays.
I wish we could, cause like we had one girl, she even had to have a knee scope after her because her extension was so bad because they braced her wrong.
Oh,
And so her brace was so off, and so like her extension was terrible.
that's horrible. That's just so avoidable, man. All right, so we good on that? Huge part. Huge part. And again, you guys are gonna play a huge role in that. If you're seeing this population, you'll think back to the day that Dr. L said, hold them back, hold them back. All right, meniscal tears. How we doing? Let's take another little break. You got 5 minutes. You gotta get some more stuff done.